Good afternoon, everyone, and welcome to today's webinar entitled Society Watch 2021, Deteriorating Mental Health, Should We Be Worried? Funded by the Economic and Social Research Council, the ESRC. I'm Stephanie Hatch, Professor of Sociology and Epidemiology at King's College London and Program and Impact Lead in the ESRC Center for Society and Mental Health, and I'll be chairing today's event. So as we know, the National Center for Social Research, NatCen, has launched the second annual Society Watch report on deteriorating mental health in the UK, drawing on some of the key data sources, including new data on the impacts of the coronavirus pandemic on our mental well-being. The report will provide an insight into public's mental health from the national mental health surveys, including new data currently being collected and analyzed from Understanding Society, as well as policy-relevant research. Today, our speakers will provide a picture of people's mental health over the life course, from childhood to old age, including some of the impacts on the more disadvantaged groups in our society. To take us through key findings, we have four speakers, starting with Sally McManus, who's a senior lecturer at the National Center for Social Research and City University of London. Sally McManus combines working at NatCen with being a senior lecturer in the Violence and Society Center at City University. She managed both the 2007 and the 2014 Adult Psychiatric Morbidity surveys and advises on the 2022 survey currently in development. Sally specializes in survey measurement on mental health and health behaviors, examining temporal trends and inequalities, including the context of COVID-19. Sally will be followed by Tim Vizard, Head of Policy, Evidence and Analysis Team at the Office for National Statistics. Tim joined the ONS in 2007 and has led several large-scale social surveys, including the Annual Population Survey and European Health Interview Survey. Tim also worked on the 2017 Mental Health of Children and Young People Survey and the most recent 2020 follow-up study, delivered on behalf of NHS Digital in collaboration with NatCen, Youth in Mind, University of Exeter, University of Cambridge, and ONS. He currently leads a multidisciplinary team of analysts responding to emerging policy areas. This includes ONS weekly analysis of the Opinions and Lifestyle Survey, providing insights into the mental health and well-being of adults and the impact of the coronavirus pandemic on people, households, and communities in Great Britain. Following Tim, we will hear from Professor Tamsen Ford, who's a professor of child and adolescent psychiatry at University of Cambridge. Her academic work focuses on the effectiveness of interventions and the efficacy of services in relationship to mental health of children and young people, with a particular focus on the interface between education and health systems. She completed her PhD at the Institute of Psychiatry and moved to Exeter in 2007, where she set up the Child Mental Health Research Group and moved to Cambridge just recently in 2019. And then we'll close with a talk by Dr. Neil Smith, head of analysis at NatCen. He is a life course social epidemiologist with over 14 years experience researching the social determinants of health and well-being in children and adults. And since joining NatCen in 2016, he has led several school-based surveys for the Department of Education, investigating character education, mental health provision, as well as the impact and rollout of the 30 hours funded child care policy on parents and child care providers. His current research is investigating the impact of COVID-19 pandemic and school closures on young people and their families. And he has recently published a 40-year follow-up study into the trends in social mobility among ethnic minority groups in England. He is a principal investigator of 2 ESRC grants, exploring the links between adolescent mental health and well-being, educational attainment, and the financial impact of the COVID-19 pandemic. Before we get started, please note that time permitting, we will take 1 or 2 questions after each speaker regarding points of clarification. Otherwise, we will address any comments and questions at the end of the talks. If appropriate, please do indicate which speaker you would like your question or comment to be addressed to. And with that, I will now turn over to Sally McManus, who will give an overview of the report. Sally?
Hello, let me get my slides up. This is like one of those old school lunchtime seminars where everyone used to have a brown bag with them. I hope everyone's got some lunch. Okay, so I'm going to do a whirlwind tour, 10 charts in 10 minutes, and I'm going to say a little bit about what we know about population trends in mental health from surveys. And in a way, I had to get the pun in with the title. I'm not really going to talk so much about COVID-19. I'm more of a warm-up act for our later speakers who are going to focus more on COVID-19. I'm looking more about what was happening beforehand. But what I wanted to start with is something we don't often think about with surveys, and that one of the key things that surveys is really useful for is kind of a check on our common sense assumptions about things. Like we, all of us tend to think we know what's going on in the world, think we know about social change. And sometimes surveys are a useful check on that. Sometimes they will confirm what we thought, and they will give us some precision, and they'll give us some evidence for that. And sometimes they will challenge our assumptions. And one of my favorites on this is a survey that was led for many years by Liz Fuller at National Centre for Social Research. It was looking at an NHS digital survey of smoking, drinking, and drug use. And what it found was that around turn of the century, there was an enormous sudden shift, which is that young people started drinking less and smoking less and taking drugs less. And people didn't really believe it until we had the survey data to show it. Now, this chart comes from a lovely paper that was produced by one of our speakers today, Tamsen Ford, alongside a team of other people. And what they did was they looked at data from the Health Survey for England, which is another NHS digital survey series, as well as from the national surveys in Scotland and in Wales. And in those surveys, there's a question. It's a question about long-term conditions, and parents were asked, do you think your child has a long-term condition, and which of these? And interestingly, over time, we see this dramatic increase in parents perceiving that their children have got long-term mental health conditions over a long period of time. But over that period of time, the same parents were also asked a series of very specific questions about particular behaviours and particular symptoms using the Strengths and Difficulties questionnaire. And using the Strengths and Difficulties questionnaire, actually, we didn't see over this period of time, overall, an increase in mental disorders in children. Now, it's not to say that either of these are wrong, it's just that they're asking different things. And it's very important that we think about what is being asked and who it's being asked of. The Mental Health of Children and Young People survey, we'll be hearing more about this from Tamsin later on. Tim has been absolutely key to this survey series as well. It included the DORBA, which is an incredibly detailed assessment conducted face-to-face. It collects information from both the child and from parents. There's also information that's brought in from teachers. There's also a whole process of clinical review of the data. So it's a very reliable tool which tells us about different specific child mental disorders. Now, if we look at the blue line at the bottom, over a very long period of time, we see pretty much no change in the proportion of 5 to 15-year-olds with hyperactivity disorder as identified on the DORBA. We look at behavioural conduct disorders. Again, we're seeing very, very little change. It remains around 5.5 to 6% over those decades. Where we do see change is between the two most recent surveys in emotional disorder. And it's not huge, but it is there. Now, the parent equivalent survey, another NHS digital survey called the Adult Psychiatric Morbidity Survey, and one that I've been involved with over the years, finds a very similar pattern, which is that in 1993, around 7% of 16 to 64-year-olds reported levels of anxiety and depression, which we would consider pretty severe. By 2014, it's just over 9%. So we're not seeing an epidemic. We're not seeing a dramatic shift, but we are seeing a shift when we're using this particular tool, looking at this particular manifestation. But of course, the survey also covers other behavioural manifestations of distress. For example, we see a very steep rise in reporting of self-harm, and that rise is particularly steep if we look at reporting from young women. Surveys are also very good for telling us about inequalities. And what this slide shows, it comes from a report that we did at NatCen with the organisation Agenda, and it looks at reporting of self-harm in the past year, and we see that there is a very steep socioeconomic gradient associated with it. Now, healthcare data is not a replacement for surveys. Surveys are not a replacement for healthcare data. They each provide us with enormous insight and different types of insight. What this chart shows us is about inequalities in use of treatment. If you have a common mental disorder and you are aged around midlife, you've probably got about a 50-50 chance that you will be receiving some kind of intervention, be it psychotropic medication or talking therapy. If you're aged 16 to 24, it's more like 1 in 4, 1 in 5 chance that you will be in receipt of some sort of treatment. Likewise, we see really pronounced ethnic differences. If you identify as white British, you're about twice as likely to be in receipt of medication or talking therapy compared with pretty much any other ethnic group in England. Now, is this because white British group as adults have higher rates of mental disorder? Now, we don't see that because the numbers at the bottom here are the mean CISR score, and actually the average symptom score is highest in the Black British group. And is it because the groups have got different profiles, for example, different age profiles or socioeconomic profiles? Well, actually, that doesn't explain the difference in treatment use either, because we find that that Black group has odds of receiving treatment about 0.27 times that compared with the white British group. Stephani Hatcher's team and others that she works with are doing much more sophisticated analyses using combined survey data from multiple waves of the adult psychiatric morbidity and other data sources, and are coming up with much more nuanced understandings of this. Okay, so everything I've talked about so far has been about samples that were recruited in field, about interviewing people in their own homes, about conducting interviews that last an hour and a half and have very detailed assessments with hundreds of questions in them. And then, of course, a year ago, more than a year ago, fieldwork stopped. And health survey data has not been available. There's been an information vacuum, and treatment data has shifted as well. So we had to adjust. And some of the other speakers today will talk about how that adjustment happened. I'm just going to talk about one particular paper that was done. On that particular paper, we used data from an extraordinary response, which is the University of Essex coordinated UK household longitudinal survey, also known as Understanding Society. Within 1 month of lockdowns happening at the end of March, they had an online questionnaire in field that went out to their very large panel. And within a month of that, that data was archived for researchers to use. Now, as we well know, now there was a measurable increase in mental distress in the population as a whole, 1 month into the pandemic. And what we are seeing, we saw right from the beginning, and we're seeing, and we'll explore more today, is that that increase in mental distress affected different groups to different extent. So some, 1 month in, some inequalities were persisted. They had existed before the pandemic and they continued to exist after. Some inequalities had widened, in particular for women and for young people, and some new inequalities were emerging, which is that we're seeing differences, particularly for parents with young children. Now, The others will be talking about how those trajectories of distress have changed over the course of the year and how other risk factors have particularly emerged around socioeconomic and ethnic inequalities that were perhaps less evident at the very beginning of the pandemic. There's a big discussion about recovery, or whether these levels of distress have remained sustained and in who they've remained sustained. What I want to finish with is looking forward a bit to what happens next and what we anticipate will be the impact on specific mental health conditions. So the last adult psychiatric morbidity survey was carried out long ago, back in 2014. And we will soon be canvassing. As soon as the local elections are over, we will be launching, because we can't launch our consultation while that's on. But once that's finished, we will be circulating a link to a consultation to get your input into what the next survey should cover. Now, I think a key thing that I hope that we've got across in these slides here is that in many ways, we don't want to change too much of the questionnaire, because what we want to look at is change. We want measures pre-pandemic and post-pandemic, and we want to be able to look at very specific disorders. And the survey will enable us to do that in some ways, because it collects information on things where we might expect to see a change in population prevalence. For example, social anxiety, different types of phobias, health anxiety, PTSD. But we are also going to expand coverage, bringing back in things like eating disorders we expect, and certainly including some questions on COVID. So we will welcome your input on that, but we can't open the consultation until the 7th of May. And just to say that anything that you want added to the survey, you also have to suggest something that comes out, because it's very space limited.
Thank you, Sally. Thank you for that fantastic bit of background. We will move on to Tim Vizard, who will present data and analysis on coronavirus and depression in adults using recent data from the ONS Opinions and Lifestyle Survey. Tim?
Great, thank you very much, and hopefully everyone can hear me now, and I'll start sharing my screen as well, and hopefully this will work seamlessly. So here we go. Great, just wait for that to start. Brilliant. Okay, so thank you very much for the introduction, and firstly I want to say congratulations to the team at NatCen for a really interesting report, and such an important one as well, looking at the mental health and well-being during the pandemic of adults and children. So as you mentioned, I wanted to talk a little bit about some data we've been collecting on depression in adults during the pandemic, but also looking first a little bit about personal well-being as well from our Opinions and Lifestyle COVID-19 survey. So a tiny bit of background, what I mean by the Opinions and Lifestyle Survey is a survey we've been running for quite a long time, but from March 2020, it was turned into a weekly survey of adults in Great Britain, which was predominantly online, but with some option for telephone interviewing as well. And it's been collecting data on the social impacts of COVID-19, but it includes also measures on personal well-being and mental health, specifically depression. Between March and October, we were achieving around 1,000 to 1,500 responses per week from a sample of 2,000 adults weekly. But since November, we've temporarily boosted this to 6,000 adults, which gives us a lot more sort of confidence in the numbers we're able to talk about on a weekly basis, from around 4,000 responses per week. So a little bit of context before I move on to talking about depression. During this survey, we've been asking 4 questions about personal well-being, covering things such as life satisfaction overall. How satisfied are you with your life nowadays? And also overall, to what extent do you feel that the things you do in your life are worthwhile? These are slightly longer term measures, but we've also been asking 2 measures around happiness and anxiety yesterday. So overall, how happy did you feel yesterday? And overall, how anxious did you feel yesterday? And with these weekly data, we do see a bit of volatility in the numbers with a bit of a zigzaggy line, but they do give us an ability to kind of see what the effects of kind of data and in the data, what effects of week-on-week changes we might see during the pandemic. And the key trends here are in March 2020, at the start of these charts here, we found high levels of anxiety and low levels of happiness, particularly quite stark on the anxious chart on the bottom right there. But we found that those levels started to move towards pre-pandemic levels, which are based on February 2020 data. And these levels stabilised during June to August 2020, before starting to see a further decline again from September 2020, which might be due to lots of things, but it's important to say there's probably some seasonality in this data as well, particularly when we move into the winter months. But quite an important point to make here is that we found quite a big change in well-being during the start of 2021, around the time of the January lockdown, where we saw levels of anxiety go quite high relative to pre-pandemic levels and data through the previous 2020 period, and also levels of happiness falling to their lowest levels we'd seen since March. Those levels have now increased again back to pre-pandemic levels, but it shows the ability to look at well-being on a week-on-week basis and the impacts of the pandemic. So, as well as well-being, we've been looking at depression in adults. And I'd like to first talk to you about a longitudinal study we did of adults. So we approached 3,500 adults who took part in 2 studies over a 12-month period on the Opinions and Lifestyle Survey. We've got data pre-pandemic, so those from July 2019 to March 2020, and also during the pandemic in June 2020. And we looked at adults who were experiencing moderate to severe depressive symptoms using the Patient Health Questionnaire, or the PHQ 8-item. And this allowed us to look at levels of depression in the population. Important note here, this is self-reported data here from a survey. And pre-pandemic, from July to March, we found that 9.7% of adults experience some form of depression. So that's around 1 in 10 adults. But when we look at during the pandemic in June 2020, we found that rate doubled to around 19.2% of adults, or around 1 in 5 adults experience some form of depression. So with this being longitudinal data, we were also able to look at these changes over time in the same group of adults. As the data would suggest, we saw the vast majority, 77.4% of adults, experience no or mild depressive symptoms during both periods. But potentially of more interest here is those groups who have either developed or had depressive symptoms. And we found 12.9% of adults developed moderate to severe depressive symptoms since before the pandemic. We did find 3.5% of adults had improved from moderate to severe depressive symptoms pre-pandemic to no or mild depressive symptoms during the pandemic. And 6.2% of adults continue to experience moderate to severe depressive symptoms both before the pandemic and during the pandemic. We also were able to do some analysis to look at who was most likely to experience depression during the pandemic. And we looked at descriptive statistics and also did a logistic regression as well to find these statistics, but I'll talk just about the descriptors here for time. So when we look at pre-pandemic and during pandemic, when we look at these numbers here, we found that younger adults, so those aged 16 to 39, were much more likely to experience some form of depression during the pandemic in June 2020. In fact, 31% of adults. And a big increase as well for those adults compared to pre-pandemic levels. When we look at sex, we found that females were more likely to experience some form of depression, both pre-pandemic and during pandemic as well. And looking at the green dot there, we can say we found 23% of females in our sample experienced some form of depression during June 2020. We also had a look at a measure of financial resilience, and by this I mean adults who were unable to afford an unexpected but necessary expense of £850. And what we found here is both before and during pandemic, it was adults not able to afford this unexpected expense who were more likely to experience some form of depression. And in fact, around 1 in 3 adults not able to afford this expense experienced some form of depression during the pandemic. and also looking at disability as well. And we found disabled adults both before and during the pandemic were more likely to experience some form of depression. And again, 35%, so around 1 in 3 adults, disabled adults, experienced some form of depression during the pandemic. We also asked adults in our survey around the impacts on their life and also their well-being. And we found here that 4 in 5 adults experiencing some form of depression said that their well-being was being affected during the pandemic. And this number was a lot bigger than those experiencing no or mild depressive symptoms. Other things we found here were around adults saying my relationships are being affected, as well as the availability of groceries and access to healthcare, and my health being affected. This was reported much more by those experiencing moderate to severe depressive symptoms compared to those with no or mild depressive symptoms. And we asked those adults who said their well-being was being affected, we asked them in what way was their well-being being affected. We found feeling stressed or anxious was the most common way adults experiencing some form of depression felt their well-being was being affected. Alongside that, it was more commonly reported around making my mental health worse, spending too much time alone, strain on personal relationships, and also feeling like a burden on others. These are things that people experiencing moderate to severe depressive symptoms were more likely to report than those experiencing no or mild depressive symptoms. So have things changed since June 2020? So we repeated this study in November 2020 during the second lockdown in England, using a new cross-sectional sample of around 12,500 adults, so a larger sample than we had in our first study. And this asked the similar questions of depression, and we found that rates of depression had persisted since the record high levels we were seeing in June 2020. And with our larger sample, we had a little bit more confidence in that number as well, with a slightly smaller confidence interval around the number. So this shows that the rates we were seeing in June had persisted over time and hadn't declined back to pre-pandemic levels at this point. So I'd like to finish on what's next, and we do have some new analysis that's going to be published next week on the 5th of May, which is going to revisit some of the things I've talked to you here, looking at coronavirus and depression in adults, but looking at the period January to March 2021. This again will be based on our opinions and lifestyle survey, but on a much bigger sample, so 26,000 adults will be included in this analysis. And this gives us a chance again to look at the rates of depression during the first few months of 2021 and compare it to the data I've just presented here. But with the larger sample, it also gives us the opportunity to look in a bit more detail at some of the characteristics. So for example, we've looked at age and sex and isolation, but we'll be able to look at rates of depression in younger women and younger men, and comparatively with older adults as well, which should give us some new insights into the data we've been collecting. Alongside this, we're also going to be publishing a report on the same day, which is looking at GP diagnosed depression in England during 2020. And this is using data from the GP extraction service, which has been specifically prepared for pandemic planning and research. And this data is going to be looking at the period of the 23rd of March through to the 31st of August 2020 and comparing that to pre-pandemic levels as well. And there's a couple of links here on the slides, which will be live. I think it's from around 9:30 on the 5th of May. And if you want to find more information on the day or anything else that we've been collecting, there's some links here to the ONS website and also to the ONS Twitter account and my Twitter account as well, which will be obviously tweeting about the results on the day of release. But that's it from me. So thank you very much for your time.
Great. Thank you very much, Tim. That was really helpful. We've had a couple of questions come in, but I think we can pick up on those in the Q&A session. So I'll move right along to Professor Tamsen Ford, who will now respond to the findings in the report and share her insights about new directions for mental health survey work.
Thank you, Stephanie, and congratulations to NatCen on a really, really important report. I really enjoyed reading it. So I'm going to talk a little bit about the report, a little bit about the children's survey that Sally mentioned, and a little bit about the additional bits that we're doing with the children's data. But first, I think it's really important to underline what a huge data gap we have in relation to children, and in relation to mental health in COVID, just the enormous signal to noise problem we have. So if you haven't seen this amazing living systematic review, and those of you who saw me at the Academy of Medical Sciences last week, it's gone up by 6,000 abstracts since I looked about a week ago. So they have been doing 3 systematic reviews, 2 of which are ongoing. Firstly, changes in mental health, either during the pandemic or pre and after, before and after the pandemic started. They did start to look at factors associated with these changes, but couldn't really find any good studies and were being so swamped that they stopped that in September, by which point they only had 43 studies and they'd abstracted data from 42 of them. And then the final group are intervention studies that relate to mental health in the time of COVID. They have screened nearly 50,000 abstracts since this began about a year ago. And yet they have only a handful of studies really that they think are eligible. And they are now beginning to fall behind with eligible studies in terms of those where the data is abstracted. But the figure in brackets is those that relate to children. And actually, initially, they weren't going to include factors to do with children, which is partly why I've escaped from being involved, because I said, well, my expertise is children. So we have a huge data gap and a high signal to noise, and it's worthwhile just reflecting on the quality of these surveys that Sally and Tim has presented, and the series of surveys in relation to children and young people, which really document my entire research career. So way back in 1998 and 1999, I was a clinical rater who took the data from parents, from young people, from teachers, both very structured data, but also some more qualitative data, to assign diagnoses using standardized diagnostic criteria, but trying to get as close to what we did in the clinic. And there have been 3 surveys, each with an element of follow-up. But obviously I'm going to concentrate on the most recent one, which figures in the report. Now, Sally talked about the diagnostic measure that were used in all these baseline surveys, but we did manage to get back to our 2017 sample last summer, but we weren't going to have the funding all the time to do this very in-depth analysis of children's mental health. So we used a scale, but rather than just use a cut point, what we used was an algorithm that takes the scores according to parents, teachers, and young people if they're all there, and it can combine them to give a prediction of how likely it is that a child or young person has a mental health condition at 3 levels. So the unlikely to have a mental health condition are almost not scoring at all on emotions or behavior. They might have a few inattentive, fidgety symptoms, and they have no impact, importantly. The probable are very high scoring, above the 95th centile. That means 95% of children would be scoring lower than them. But more importantly, there needs to be some impact of those difficulties, not just a high score. So it's quite conservative. And obviously the possible children are somewhere in between. Now, for the national survey, we had parents of those up to the age of 16, 17 to 22-year-olds were obviously reporting on themselves, and between 11 and 16, we had both parent and children, which increases the accuracy. The bottom line, using the same algorithm applied in 2017, so it's important that you look at the 2020 report itself and not compare the figures for disorder with the original survey that uses a different measure. But when we're comparing apples and apples, you had 1 in 9 children had a probable mental health condition according to the SDQ algorithm, compared with 1 in 6 in July last year. Now, we saw this increase in both genders, all age groups, and as in 2017, and interestingly, as Sally highlighted with the adult services, young women seem to be doing particularly badly. The other thing that I think comes out from pretty much every data source reported in the Society Watch report is the strong association with deprivation, with financial instability or food instability. The other important thing about the children's survey is the strong association found throughout in every single one of them, but they're also in relation to last summer, is the strong association between parent and child poor mental health. A family can probably only be or function as well as its unhappiest member. The other thing we saw is quite a lot of risk factors. So the graph you're looking at is comparing by the likelihood or not of a mental health condition amongst young adolescents in the left-hand set of bars and emerging adults in the right-hand set, whether they thought lockdown was making their life worse. Now, in the whole sample, just over 40% thought that their life was worse. Some of them were, equivocal, but actually there was a chunk of children who thought their life was better. This was seen in other surveys, including the Oxwell survey, not mentioned in the report, but this was 19,000 youngsters reporting on themselves between age 8 and 18, collected via schools. The same thing, roughly split into a third who were happier, a third who were unhappier, and a middle group where it wasn't making much difference. There are also some risk factors that are worrying. A cross-sectional association with lockdown, which is with mental health conditions, which is not to say it's causal. It could work both ways for feeling lonely and for sleep disruption, but also other risky behaviours in other surveys like drinking, substance misuse, and gambling. But really worrying because there are suggestions that these predict disorder, and they are more prevalent amongst the youngsters with a probable mental health condition, but they are also more prevalent than they have been in the population and might be further undermining our children and young people's mental health. So on to the final section of my talk, which is to talk a little bit about the bells and whistles that we've been adding on to the pure survey data. So I have got funding from the UK Research and Innovation Fund in relation to COVID, but working alongside NatCen, ONS, and NHS Digital, very much in partnership. We are going to put some semi-structured interviews with a purposive sample selected for certain characteristics that I'll go into around each wave. So we have the 2020 wave, and those interviews are about to start. The 2021 wave, the data is in. We don't know what's in it yet, but we will be contacting people who look like they might have an eating disorder, and also those with special educational needs and disability to find out about their experience. In this last wave, there was an opportunity to opt in to being contacted to use a mood monitoring app. Now, this allows youngsters to monitor their mood on a daily basis, but also to record nasty events. And then it allows them to look at the feedback and see how they're feeling. Obviously, it's got access to support within it. And we're going to do a period of data collection of 3 or 4 weeks, as soon as we got ethics to do it. And we are going to do a third wave of the survey as funding's running short through the app. And ideally, another set of semi-structured interviews, no topics identified for those, because we want to be fleet of foot and we want to be responding to what the policy imperative is, as we have with eating disorders, for example, and special educational needs. And then in the summer holidays, we want to do another bit of mood monitoring to see how that goes. So the wave one interviews are going to be about services, because one of the things that came out, and it's reflected in the national statistics for referrals to child mental health services, that only about half of those who had a mental health condition and were worried about it, they've got some concerns, the sizable proportion of them, about half, had not gone to get help. And that's kind of worrying. So we will be sampling people on whether or not they thought they were concerned, whether or not they had a mental health condition, and whether or not they've gone to get services, to try and get the range of those experiences, to work out why that's going on and what we could do about it. Now, this, for those of you who are very quantitative, you might wonder, well, why would we do this? In fact, there is precedent. I did this for my PhD, and the quantitative data about service contact was fed back into the survey data, whereas you get a lot more richness about barriers, waiting times and things by doing this. The other thing we're going to do is this, what's going on with the people who are saying lockdowns made their life better? And if it has made it worse, what's made it worse and what could we do about it? So just to pad out, in the 99 survey, 10,500 children, we interviewed people at about 18, 20 months in relation to service use prospectively, and then again off the resurvey. So this is not a new technique really, but we've had to reinvent a way to do it. So we have co-produced with NHS Digital, with NatCen, a way of getting consent that's got through iGuard, so we can go ahead with it, where NatCen will send information, just a brief flyer, not a full information sheet, to those who've consented for further contact. Having identified the people we want, they can then opt out for 10 working days. Those who don't opt out, their details are passed back to us to contact, to go through the full research process, the full consent process. I won't dwell on this because I think we're short of time, but this just gives you a sense of how we're trying to manage not burdening too many people. So we're going to prioritize the service use interviews, and if you are qualified for one of those, you'll be let off from the lockdown interviews. We will go straight to the parents of young people, but those who are old enough to consent for themselves, we will contact them. But then through parents, we are going to try and talk to some of the younger adolescents as well. So these will be semi-structured interviews with a topic guide that will be transcribed and analysed qualitatively for the data that isn't quantitative or very structured. Just to put some more detail on the app, so it's personalised. Parents will be contacted to make sure that they're aware that their young person is being involved with this app, and it means we have an email for both the parent if the young person is under the age of 16 and for the young person, and then it will personalise everything. It will ask people to rate how they feel, what they're doing at the time, give them some certain keywords, and as I said, they can reflect over time how they're feeling, and then it allows them to log unpleasant events. So this is an example on the left of what they can see back, and an example of one of 3 screens with places to get support. And just to indicate, we can push the questionnaire out through this app. Now, obviously, the day-to-day data, particularly when we know everything so much else about these other young people, and the plan is very much to reintegrate the data in a secure data resource with the original survey data, which will be fascinating. But it's also partly a feasibility about how many people will do this. Well, so far, just over 70% have agreed to have their contact passed to us. Now, how many of that will convert into signing up and staying engaged, we don't know. But I think this is a potentially really exciting augmentation to survey design. And I'd just like to thank my research colleagues. and my funders and my collaborators, and I will stop there.
Great, thank you, Tamsin. That was really interesting, and we'll certainly come back to it in more detail during the Q&A. In the interest of time, I'm going to move on to Dr. Neil Smith, who will present the different financial experiences faced by the UK population before and during the COVID-19 pandemic. Neil?
Thank you very much, Stephanie. So this is an overview of a ESRC UKRI funded project, which was part of the rapid response to COVID call, that is making use of the data that was collected as part of the Understanding Society COVID study. And it's looking at the relationship between financial changes during the pandemic and consequent mental health. So I'm sure, as we're aware, last spring, the UK government put in restrictions to protect the population health. And this impacted many people's ability to go out and do their jobs and earn money to support themselves and their families. Because of this, this is really important to health in particular, because financial well-being, we know, is a well-established a risk factor for poorer mental health. So this investigation aimed to look at which groups in society were most badly affected financially, how they were affected in terms of how did this translate into what they could do with their daily lives financially, and what impacts this therefore had on their mental health and well-being. In April 2020, Understanding Society went into the field to complete a short web-based survey of approximately 20,000 participants who were in the main survey that has been running for the past decade. So Understanding Society is blessed with an enormous decade-long baseline for these 20,000 participants, having collected an enormous array of contextual, social, demographic and economic information over this period. And we're able to link this baseline information to the financial circumstances of these individuals during the COVID pandemic between April and January 2021. And by doing so, we could link the financial experiences to their mental distress on a near monthly basis in over 12,000 people aged 16 or older living in private addresses across the UK. To supplement this, we've also worked with our friends at the Money and Mental Health Policy Institute, and we've run a series of focus groups with 14 individuals to discuss the lived experiences of living with mental illness during the pandemic. So during this quantitative study, we have used the mental distress measure known as the General Health Questionnaire 12-item version. So this is a non-specific measure of psychological distress. It typically captures domains such as anxiety, depression, social functioning, loss of confidence, perhaps. And it can be reduced to a score of 0 to 12. And then we use a score of typically of 4 or more to indicate a clinically relevant risk of mental distress. Financial experiences during the pandemic were collected using a series of variables, a series of questions about how people's finances had changed between April and November 2020. And it talked about changes to individual and household earnings, benefits, changes to debt, spending patterns, and what people did behaviourally to cover specific losses due to the pandemic. And lastly, we used a specific technique called latent class analysis, which is a highly data-driven approach to look at all the data and to pull out what correlations there were between all these different financial characteristics. So it's a very data-driven approach. We didn't assign people into particular predefined categories of people doing well, people doing not well. The data told the story for us. And by using this technique, we were able to cluster together people who shared similar characteristics and similar financial experiences through the pandemic. And what we found was 6 different groups and 6 different pathways taken by the population through the pandemic. The majority of people were actually undisrupted. Well, a large proportion of people were actually undisrupted financially by the pandemic, 43%. And nearly a third benefited financially during the pandemic. And by benefited, that means that they managed to save money or reduce their debts. There was a group of copers who took a small hit to their incomes, but they got by with few behavioural changes to their spending patterns. There were self-supporters at 13%, and this group tended to dip into their savings to supplement the financial hit that they had taken. And then there were more severely affected groups, the help seekers. Now, these are a group of people who are newly reliant upon claiming financial support payments and benefits during the pandemic, and who also undertook several changes to their spending patterns. And lastly, were the multi-strugglers. These were people with long-term financial difficulties before the pandemic, and they undertook a wide range of different behavioural changes in order to reduce their spending during the pandemic. So who are these people in these groups? Who are they? What sectors of the population are they from? So some of them are slightly younger than others. The multi-strugglers and the help seekers, the most badly affected financially, tended to be slightly younger than most of the other groups, especially the undisrupted group. This is the standout age-related difference between the groups. The undisrupted group tended to be much older, generally over the ages of 60. And so this is no real surprise they were financially undisrupted, because they, by and large, weren't at work to have any financial disruption. They weren't drawing an income before the pandemic. But as the multi-strugglers and help seekers were slightly younger than all of the other groups. We looked at differences by ethnicity, and I apologise for using the BAME group here. I've spent 10 years investigating ethnic minority health inequalities, and I fully appreciate BAME is masking a wide range of experiences among the minority groups. But as with secondary analysis, we have to be pragmatic, and we're limited here by sample sizes. And even if we do aggregate, we do see large differences between minority groups and the white majority. Minority groups were twice as likely to be multi-strugglers, help seekers, and more likely to be self-supporters. These are the more severely affected groups of people. And the minority groups were less likely to have been undisrupted over the course of the pandemic financially. Patterns of support, that is government support schemes that were put in place, patterns of support tended to vary by need. Now that in itself really isn't very surprising. If they have greater needs, they will receive more support. But it was the types of support that characterised each of these groups that was so interesting. The multi-strugglers, the people with long-term financial difficulties, they're overwhelmingly more likely to have new successful universal credit claims, and relatively speaking, a low rate of being furloughed, mainly because they weren't in work to be furloughed from before the pandemic. And the help seekers group is very interesting because they were less likely to be dependent on furlough and much more likely to seek self-employment grants and, of course, universal credit claims. And when we look a bit deeper into this group, we can see that this group did have a high proportion of self-employed people. So that's the financial impacts on the population. What about the mental health impacts on the population? And by and large, this data is from Understanding Society. By and large, we saw a very strong association between increases in financial distress and the national lockdowns taking place, with a very large uptick in poor mental health in the April fieldwork period, and then declining over into May and June, and then returning to pre-pandemic levels over the summer. And then a slightly less sharp uptick in the autumn and winter. The reasons for this could be many. There is much more regional variations rather than one big hit that happened in April. And people were in different tiers, and so anxiety didn't all hit the whole population at the same time. Or it could be that just people were more comfortable with the extraordinary circumstances and were less anxious than they had been previously in the year. But what we can look at is our groups before the pandemic to see what position they were in before the pandemic struck. And we can see that pre-pandemic mental distress was highest for those who were about to go on and struggle the most. So in other words, the multi-strugglers at the pre-pandemic, the multi-strugglers were the most vulnerable group, and they already had the highest levels of mental distress. And the help seekers and self-supporters also had high levels of mental distress, and whereas the undisrupted beneficiaries, much lower levels pre-pandemic. But what happens when we follow these people through over the course of the past year? So this line graph shows the levels of mental distress in these groups over the past year based on Understanding Society data. We can see immediately some groups have higher levels of mental distress at the outset, and then it increases and remains elevated over the course of the pandemic for all groups. All groups, regardless of finances, experienced higher levels of mental distress during the pandemic. So the first thing we can say is this is confirming that it's a well-established link between mental distress and financial distress. But secondly, this also shows that these are pandemic-specific responses. There are clear differences between people's circumstances that have been shaped by the pandemic and which have affected their changes to their mental well-being. And in particular, some groups were affected more than others. So the multi-strugglers can be characterized by having high levels of distress before the pandemic, having the highest levels during the pandemic, but interestingly, by January, their levels of distress had actually returned to pre-pandemic levels. Meanwhile, if we look at the help seekers group, this group, about 29% of this group had clinically relevant levels of mental distress pre-pandemic. And again, this went up and down with the lockdowns, but what's happened over the winter is that their mental distress has remained elevated and has actually continued to increase. And so we can see a gap between these two groups' mental health at the start of the pandemic. And then when we look at the end of the pandemic, that gap is completely closed. So these help seekers have experienced the sharpest increase over the course of the pandemic, even if the multi-strugglers have overall generally had the highest levels persistently over the pandemic. And for these multi-strugglers, this persistently elevated levels of mental distress has begun to translate into new diagnoses. So this chart is showing new diagnoses of a mental health condition between May and January 2021. But the help seekers, they may have had the sharpest uptick in mental distress, but this is not yet translated through into the health services. It's not yet translated through into a formal diagnosis. So I say not yet, it might not, but it certainly shows that multi-strugglers who have chronic financial difficulties have that has translated through into a diagnosable mental health condition. And the help seekers, if they're not, if we don't look after their needs, they could well join the multi-struggler group. But of course, this is a lot of data, and behind every data point, we need to remember is an actual person. And so we went to listen to people with lived experiences of mental health problems or caring for people with mental health problems over the course of the pandemic. And what they tell us is that there is a real concern among these people about widening health inequalities. These people are already in poor mental health at the start, and there's a chance that it's going to make them worse off as a consequence of the pandemic. One person said that they wouldn't take time off during the pandemic when they were unwell with mental health problems because there was an air of employers wanting to make cuts. And so the problem there is that people continue to go to work when they were extremely poorly, and then that just puts them, that just is going to perpetuate their mental health problems and make them and leave them in chronic poor mental health, which they probably wouldn't have experienced. There's also the fact that some of the new interventions didn't apply to people who were already on benefits, these legacy benefits. So new applicants to universal credit got the £20 uplift, but people who were already on universal benefit for a period of time, they didn't see that, that uplift. They were perceived as left behind. So they got less, even though they had chronic mental health conditions and were in poorer health. Notwithstanding the fact that people who are newly on entered the benefit system are more likely to be in better health because they've only just joined that benefit system. So there was a sense that health inequalities may be widening. But more positively, like probably most of us, we've had to adapt and change the way we live our lives. And in many cases, some of these adaptations have actually been quite beneficial. And this was the case with some of the government systems, in fact. Dealing with the Department for Work and Pensions became a bit easier during COVID because people didn't have to go in for face-to-face interviews. Extensions were more flexible and less stressful. And people didn't have to spend precious money, such as the £5 bus fare, in order to go and receive their benefit. And secondly, it's brought to the fore employer responsibilities towards maintaining a mentally well and happy workforce. So employers are now much more aware of looking after employee mental health, and people spoke of having flexible working, buddying, and mentors to help people at work when they had high levels of anxiety. So the key findings of this quantitative analysis have been that mental distress increased in all groups over the pandemic, but the largest increases were seen in this help seekers group. And those were the people who were new to the financial support system, and they needed this support after the pandemic hit their income. And they tended to be, or more likely to be, the self-employed section of society. People who were already struggling financially when the pandemic hit also struggled, but their levels of distress have now returned, we think, until more data arrives, to pre-pandemic levels. The steepest increases in mental distress have not yet translated into mental health diagnoses. These people have not yet entered the healthcare system. And I say yet, they might not. But the most economically vulnerable, the multi-strugglers with chronic financial difficulties, well, they have recorded a significant increase in new diagnoses, potentially due to those chronic financial stresses. So the big question will be, what can we do about these declines in mental health? Well, I think the important thing from this research is that it goes beyond just re-establishing the link between poor financial circumstances and poorer mental health. What this has done is it has isolated pandemic-specific financial circumstances and poorer mental health. And we need to know this because as we go down the road to recovery, we need to know who these groups are and how they got in that position. And once we understand these groups and what their position is, we can set about fixing it. There are two ways to look at this, though. There could be that if financial interventions have prevented larger declines in mental health by being implemented, just logically, it means that the withdrawal of those interventions may lead to a further decline in mental health. So we need to think very carefully about how these interventions are withdrawn. Having a cliff edge, an overnight turning off of the tap just as quickly as the tap got turned on, is liable to be very harmful to individuals' mental health, not least because the anticipation of that cliff edge in itself is going to be anxiety inducing. So we would need to think carefully about tapering of the withdrawal of support mechanisms. However, there may be the case that financial interventions have not actually supported groups at all. Maybe the help seekers have had a big uptick in mental distress because those interventions relevant to them have not reached them. They weren't accessible, or they just haven't been able to cover their costs. In which case, this suggests that the intervention hasn't worked, so we would need additional interventions for financial support. And more short term, we know that they have additional mental health needs as a consequence of the pandemic. So we need to target services to tackle those new needs in this group. And lastly, this isn't over. We need ongoing monitoring needed as part of the recovery and the levelling up process to return these people back to where they were before the pandemic struck. And I just want to end with a tribute to sort of Jonathan Van Town with a curious analogy here, but it's as if the pandemic wave has washed up many people in the population and washed them up the shore and deposited them on the beach. And where they rest now is indicative of their levels of mental distress. The multi-strugglers are stranded high up the beach. But as that wave recedes, some people will be returned to their pre-pandemic state, but others are going to remain stuck on the shore facing those mental difficulties that the pandemic wave has created for them. So it's absolutely vital that we recognise the range of factors that got those people stuck high up that beach in order to understand what it will take to return them back to their pre-pandemic state and to give them the better quality of life that they lived before the pandemic affected them financially and ultimately affected their mental health and well-being. So I should just wanted to acknowledge as well, this was a large NatCen project, and it was a significant contribution here by Dr. Isabel Taylor in the analysis team as well. So I just wanted to acknowledge. But thank you very much.
Thank you, Neil. Thank you for that very comprehensive presentation. And thank you to all of the speakers. It's just been a really informative and clear set of presentations. And now we're going to move into the Q&A session. So I'd like to ask the speakers to turn on their cameras because we've got a number of questions, some of which are directed to all of you. Unfortunately, Tamsen Ford has had to leave us, and I'd like to just thank her for replying to some of the questions directed to her before she's left, and we'll make sure that any additional questions are directed to her and will be passed on. So we've got a number of questions that have come in to the Q&A box, but please do continue to add your questions as we get into our discussion. I am going to touch upon some of those that have already been answered, just for the sake of those who are watching this again on YouTube. And I think I'll just start there. There was a question directed to Sally McManus, asking if there was any data on profile for men by income and or age. Thinking about what we know, that there are men far more likely to commit suicide, and often this is associated with family separation. Sally, could you please comment on that and in a little bit more detail?
Yeah, absolutely. And this is absolutely key, and Michael's absolutely right that men, particularly men in midlife, are more likely to take their own life than almost any other demographic. And this has been the case now for a good decade. It wasn't always this profile. This was a profile that emerged around a decade ago. We have carried out a big study for NIHR, which we published a couple of years back, and I'll circulate the link to that report, where we focused particularly on midlife men. We looked at trends in survey data over long periods of time. We looked at linking up Health Survey for England data from over 180,000 people to suicide as an outcome, so that we could explore this. But we also, importantly, and I think a theme that's been coming out a lot today, is carried out qualitative work with men, particularly in midlife, around what sorts of support and intervention needs they felt would benefit them. Because that's different, and having a gender-informed approach can be very important. Socioeconomic issues were key, stigma was key, and responses of services, and sometimes the power imbalance in services and issues there all emerged. So absolutely. In terms of suicide in the current COVID context, work by Anne John and Lewis Appleby and David Gunnell and others has been really important at picking up on that we haven't seen any evidence yet in the UK, but also globally, of an increase in rates of suicide. So it's all very cautious, but this is a positive note at the moment, but one where we just need to watch and wait, because some of the socioeconomic pressures that Neil's been pointing out are well-known risk factors in relation to suicide, particularly in relation to suicide in midlife men.
Great, thank you, Sally. And then the next question is for Tim, and it's really regarding whether or not the findings that you reported today from the Opinions and Lifestyle Survey could be analyzed by UK region, especially important given the fact that we know that place matters, as we've seen in the last year.
Yes, so the data we publish on the Opinions and Lifestyle Survey is possible to analyse by region. I think a lot of the data we put out, in particular in our weekly tables, look at government office regions, so splitting England into the 9 regions plus Wales and Scotland. We have put some reports out as well that dive a bit deeper by subnational differences as well, so looking at kind of much more local areas across Great Britain. They are published on our website as well, and I think we've recently published a report looking at loneliness and well-being by local areas, which I think there's quite a neat chart that you can zoom into areas to see levels of well-being, which I've posted a link to that report in the response. But yes, you can do that, and our data is available to researchers via the ONS Secure Research Service as well. I believe that I think you can access that data by sort of at least government office region for further analysis as well.
Great, thank you, Tim. And staying with you in your presentation, there was a question: is the baseline for February 2020 typical of data pre-2020? Could the levels of anxiety already have been raised in 2020? The pandemic was already getting a lot of coverage, and many may have already been anxious.
Yeah, it's a really good point, and you're right, the pandemic didn't necessarily start in February 2020. It was potentially our most comparable data point before we started collecting our weekly data. I think there's other sources that we have available within sort of the personal wellbeing programme, which has a look at trends over multiple years, and what we have found is that levels of anxiety did seem to be at a slightly higher level before that February 2020 pandemic level, so maybe they were slightly on the decline or increase at that point, but yeah, it was a comparable reference point, but it doesn't necessarily mean that was atypical of what we were seeing before. But I think it's important to note there were other things going on before February 2020 that were not COVID related, which may have also led to a slightly atypical kind of well-being picture as well.
And Neil, there was a question specifically about mental health. You were quoted as new mental health diagnosis. Can you say more about how that was defined? Whether or not it was self-reported in the survey or data linked to GP records or other?
It was through the survey instrument. There was no data linkage involved, and respondents were just asked if they'd been told that they had a health condition by a health professional. So it was just in response to a survey item. So there are that's likely to be slightly confounded or biased by people's access to that health practitioner. So it's not perfect, but this isn't not the time to get perfect data unless we can link it.
Great, thank you. And that sort of following on, just a comment to all of you, really great talks. And maybe if all of you could comment on this. And Terry's asking, can we say if changes can be viewed as understandable psychological reactions? Is there a risk of medicalizing these findings, or should we wait and see as the pandemic hopefully passes? Of course, this is not to say that we should not be helping children and adults who are suffering, but the implications of the longer term scarring effects or not are surely important and potentially more concerning. Possibly a question for Tamsin, but I believe the panel could address this. So starting with Sally, could you comment?
Yeah, I think it's really key to note that all our data collection over this past year in these surveys has been around mental distress. So, and a lot of the intervention responses that we've talked about have been about socioeconomic support. So in some ways, there has been a tendency to try to avoid medicalizing what we see as a anxiety response, a low mood response, and to recognize that much of that is to do with the socioeconomic circumstances that people find themselves in. What I think is key is that with the next adult psychiatric morbidity survey, for example, we'll be able to start looking at some of the longer term implications. Just to mention that Terry is key in that survey series, having been involved with it since 1989 or something. Has a really good understanding about how for some individuals in society there may well be long-term outcomes, but that we shouldn't second guess this. And this is one of the things from surveys, is that sometimes we think we know what's going to happen, and actually we need to anticipate, because we need to develop hypotheses so that we make sure we collect the right data, but we really don't know yet what the long-term implications might be, where there's clinical relevance and impact on services and service provision.
Great, thank you. Tim, any comments?
Yeah, just obviously to echo Sally's points there as well. And I think what we've been trying to measure is kind of self-reported, how people are feeling in terms of personal well-being, and using a measure that maybe people would normally be asked if they were experiencing some form of depression. But I think it is an important point. Obviously, a lot of this is a natural response to what we are all living through at the moment. But I think it shows probably the importance to try and monitor that going forward as well. So this gives us a picture where we are now, but if we continue monitoring this, we can see if this is a natural response to what we're going through, or whether there are longer term sort of implications that will follow. I think Sally's point around the adult psychiatric morbidity survey, I mean, it's very timely that's going to be carried out in the next year or so, because that will give us a really detailed picture of the mental health of adults. And we also have the studies going on children as well, which is equally important.
Thank you, Tim. Neil, any additional thoughts?
Yeah, I mean, I suppose I might pinch a bit of sort of Simon Wesley's quote here, though, that these are extraordinary times, and to be a bit anxious about being told by the Prime Minister on a Thursday night that you can't go to work indefinitely is going to induce anxiety. That's a completely normal response. And yes, there is a risk of medicalizing something that is a normal response, but it's about capturing when normal dips over into sort of something that is then really going to affect long-term quality of life. And we can monitor those individuals, but we also know what the main risk factors are for, you know, chronic mental health conditions, and we can identify people with specific vulnerabilities already. People who are from who are living in long-term poverty, in low-income households, or even going back, looking in family histories, looking whether to identify if they've got adverse childhood experience history, and the pandemic seems to have affected them in particular, then we can focus our attention and our services towards those. So it's about recognizing, I think, that the pandemic might be a trigger, but it's that certain sectors of society are certainly more vulnerable to being triggered. But it shouldn't just be perceived as, you know, all of the, as those graphs showed, just about everybody had raised levels of anxiety. Yes, that doesn't mean everybody has got a mental health condition. And just one further point, actually, the general health questionnaire that we've used and has been very widely reported on, you've got to question how pandemic proof is it when it has items in it like, are you able to go about your day-to-day activities like usual? But again, other measures do pick up, increased levels of depression. It is there, but some of these tools might not be, well, they weren't designed for this situation.
Great, thank you. And Neil, staying with you, we have a couple of related questions. First, directly to you, and then to the rest of the panel. A question, it says, thank you for your presentation. Sally's presentation highlighted the different mental health experiences of parents in the pandemic. Was there any evidence of parents of dependent children being more or less likely to fall into the various clusters for financial impact?
Yes, there was. And if the person would like to download our wonderful briefing paper from the NatCen website, they will see a bar chart showing this very thing. And I'm just looking at it now. So you can see that the help seekers in particular were more likely to have children. And by and large, were more likely to be female as well. We haven't put the two together, but they are certainly associated by implication as well.
Great, thank you. And the next question is just to the wider panel. Can the panel give some insights into why so many moms and their children have poor mental health? And really important, thinking about how we translate these findings into policy and action. What policy interventions do you believe can help? Neil, would you like to start? Or we can move on to Sally. Sally, would you like to come in?
Well, I think both Neil and Tim, mine are older, but both Neil and Tim have very much been living the experience this year of having school closures when you have small children. And there's been some very interesting analyses of Understanding Society done about the distribution of labour that often generates within households. I don't think that's been the case with Tim and Neil, who've certainly done their fair share. But in many households, that has had a tendency to disproportionately fall on women. I think the sort of there was a very interesting shift in terms of the pandemic response about the prioritising of keeping schools open, and for schools being one of the last things to go. I note that Denmark was a country which has had very stringent social distancing restrictions right from the very, very beginning, but kept schools open. So from within about a month in, they were reopening their schools, but recognising this is something we're going to prioritise at all costs, and we're going to cut everything else in order to make that happen. So there's something about what a society values and what things we will keep schools open but pubs shut. That's a better balance, perhaps. There's always all sorts of complicated trade-offs, but this is something that both benefits children, or can do. Tamsin highlighted the very interesting thing that for some children, going to school can be a stressor, and they have benefited from spending more time at home with parents. But generally, it's better for children and it's better for parents. The impact not only of school closures, but of nurseries has been quite profound and has led to all sorts of shifts in terms of labour within the home.
Great, thank you, Sally. Tim, would you like to come in?
Yeah, sure. So probably not best place to comment on the policy side of things, but more from the kind of the data we've kind of seen. And we did explore as one of our kind of topic areas in the past, looking at the effects of kind of homeschooling, particularly during that first period of homeschooling at the start of the pandemic, and then again at the start of 2021. And not necessarily mental health, but looking at kind of the well-being measures again. And we found that both parents, male and female, were saying that homeschooling is negatively affecting the well-being of their child and also of their own personal well-being as well. I think we found that kind of increased during the second lockdown, the second homeschooling period that many of us probably on this call, myself included, was personally experiencing at that time. So maybe not any kind of direct answers to it, but I think there's obviously data to support that, and I appreciate it's obviously quite a key policy area that should be looked at, no doubt.
Great, thank you, Tim. Neil, did you have anything you wanted to add?
I think it's very difficult. I mean, this week the conversation has turned to just scrapping shared parental leave. So when we're talking about the shared burden of responsibility in households during the pandemic, it's like we can't even get our childcare paternity maternity rights. So dealing with this strange situation is clearly going to be very difficult. I think just there was much talk about returning to sort of traditional gender roles during the pandemic, with women picking up more of the house sort of keeping responsibilities, and to some extent that's true. And I think we could have specific policies, but I think it'd be a lot of many different little things that induce a culture change, and to begin to appreciate a sort of a caring economy really does exist, and it's not just about going out to work that counts, but not going out to work and still being valued, still giving a value to society is something that needs to return. I worry that that's taken a bit of a setback, and suddenly being at home was no longer really valued.
Great, thank you. And I think carrying on from this and just sort of thinking more broadly, another question's come in for Neil, wondering if you had any thoughts on what else might be needed for those left on the shore, aside from other than suddenly withdrawing their financial support. You talked about tapering. Are there any other thoughts on what's needed with regards to your findings?
I think our focus group respondents answer that for themselves, and they say that there are all these wonderful interventions that can help people, get back down the shore, but they don't know about them. They don't know where to go. They can't access them. And in particular, if you're already in poor mental health, you're not really well equipped or in the best position to be wading through hundreds of pages of PDFs and filling out forms and visiting your government portal and all sorts of nightmarish scenarios. And so I think in many respects, much of the support is there, but it's just not reaching those. Like many cases, interventions don't reach those who are in greatest need.
And then sort of shifting gears now a bit, there's a question here for Sally. Sort of curious about whether or not the risk factors for UK adults seem to echo what you would have seen in risk factors in other countries during COVID at a population level.
That's really interesting, and I have to say I'm not that aware of what the risk factors have been in other countries. But one of the things that I think that many of our surveys have not picked up on, which is a major potential risk factor, is the digitally excluded. Now, our surveys have based. I mean, some of ONS's work has been telephone based, and actually some of the extension work on Understanding Society has also been telephone based. An analysis Understanding Society team have done of the telephone based work is that those who were digitally excluded, who didn't respond to surveys online and perhaps don't have good connection digitally, were suffering more. And this is a group that we've been missing from much of our research, but it's also a group who I expect finding it very difficult, even more difficult than the members of the focus group who are talking about this, in accessing health and intervention, getting the information that they need. So there is a key group. The other groups that I think that have really emerged where the inequality gap has widened as a pandemic response, and which I expect may well be similar in other countries as well, are the increasing gaps around ethnicity, which have certainly exacerbated during the pandemic, and we don't know what the long-term consequences of that are going to be. And then the other, I think, is the resurgence, building on Neil's work, of socioeconomic disparities and the long-term consequences of that. But they seem to be the key ones, which I imagine have got international relevance.
Great, thank you. And you mentioned the disproportionate impact on ethnic minority groups. And we know about the limitations in many of these national surveys with regards to inclusion of ethnic minority groups. And I wondered if the panel could please comment on what they think can be done to address this issue, particularly what we've seen in the data that was presented today. And this disproportionate impact, particularly in terms of both in terms of the economic situation as well as mental health. And with the appreciation, Neil, you were commenting there about having to aggregate these groups, and we all know how difficult that is then in translating those findings. So just, I guess that question is twofold about what can be done about this issue in terms of increasing the levels of inclusion, and also what we do with the data that are available in terms of translating those findings given those limitations. Sally, would you like to comment? I know this has been something that's come up with APMS.
Oh, it's a terrible problem with APMS, and that it's a random probability sample, so the number of people in there is simply too small to be exploring these issues properly. The last time that there was a proper focused minority ethnic mental health survey was in 2000. This is more than 2 decades ago. We are able to do minority ethnic boosts on our national surveys, and in some ways that's actually, we're at a step change now because of the potential scope for sampling from improved care, primary care access records. So there could be, but this is an area that has absolutely got to be a priority for the next mental health survey if we're to be able to capture what we know the emerging widening ethnic inequalities that have happened during the pandemic, what that might mean for mental health going forward. Also, a lot of importance about embedding, and we've talked about this a lot today, qualitative and quantitative techniques, so that we're exploring things in a lot more detail and getting people's own perspectives and not just the rigidity of the survey, which asks certain questions from one perspective. So that I would say would be another key thing to integrate within these studies as well.
That was something that was great to see in Neil's study, that mixed methods approach and how rich that made the findings. Neil, would you like to come in and comment a little bit about this limitation in the data?
Yes, I mean, I love understanding society as a data set. I think it's the most wonderful thing, but its ethnic minority boost is really not as good as perhaps I would like it to be. It's almost very traditional in the groups that it has. It doesn't really capture recent waves of migration in the ways that it could. And that's the issue that we have with secondary data collections. They're probability samples, they're hideously expensive, even though that they give us the best possible results. And it's really encouraging that the work that people like Tim are doing at ONS, and in particular like data linkages, and the door that's just been crowbarred open by the Digital Economy Act. It's like something we've got this act in place to enable us to link data to surveys, to other data sets. And I think people just were a bit scared to use it because it was new. And then suddenly there's a pressing need and we can do it. And now the door is open. And so I think once we can use data which captures minority groups or rare groups of interest, without them having to consent to be involved, and we will then have the sufficient numbers because we've got population level data, then I think we will begin to get somewhere. But at the moment with our populations, our random probability surveys, we have to use horrible terms like BAME.
Well, I think the Cabinet Office is pushing us not to use that term, thankfully. But I guess Tim, you may want to come in here, and I guess it's twofold. It's about what we can do with data linkages, but also thinking about how we increase the trust in research. Thinking about the report that the Wellcome Trust released last summer, and about the mistrust, by looking across ethnic groups and how that differs. Just what we can do to actually get greater involvement when asked in national surveys. Tim, did you have any comments or thoughts?
Yeah, I did. So it's obviously always been a challenge with the survey data that we deal with, and regardless of how you design a survey, I think there's always going to be those biases of the populations that you most want to reach that potentially are hardest to reach as well. So I think regardless with survey data, how it's designed, there's always going to be that bias and that kind of challenge, and in the worst scenario, trust in the data as well. But I think there's, as Neil mentioned, and kind of the opportunity with administrative data and data sources. So looking at GP registered data, looking at IAP data both from NHS Digital, if we can link this on to other data we hold. There's a census, which hopefully we're all aware of and have taken part in. That data will become available in the future, and there's great opportunities to link that to administrative data and see if we can answer some of these questions using kind of diagnostic data that might be held at GPs. But again, there will be limitations, and I think going back to the trust, I think it's being really transparent about what we can answer and what we can't answer. And I think mixed mode as well, which I think we mentioned a bit earlier, not just trying to answer things quantitatively, looking at kind of focus groups and trying to reach those hardest to reach in the population is probably the best way to build trust, really.
Great, thank you. Sally.
Well, it's not inappropriate to ask because you're a chair, but I know that you have led a large-scale survey, and you have used extensively the data from national surveys, and you have done a lot of work in this area. So as people collecting this data, I would be particularly interested in what you would suggest in this area.
Thank you, Sally. I think what I would say is that it requires extensive involvement and engagement in various communities, however they're defined. But I think particularly really thinking about issues, how do we embed reciprocity within our research process by way of engagement, so that we make sure that these types of findings and information actually get into the hands of people who are mostly affected by it. And so oftentimes what that means is utilizing ongoing engagement. So for example, not just thinking about when we're ready to do a project, but really, developing, long-lasting relationships, particularly through the third sector. I think if you're thinking on a national scale, really, and really appreciating and respecting what third sector organizations, volunteer and community organizations can provide by way of evidence, a knowledge base that can really complement what is done, for example, in more academic sectors or in the sort of policy or analytic sectors so that we all work together in a sort of cross-sector approach, but really emphasizing what are we giving back and how is this translational? Because I think that there's a lot of feeling of just, well, we've had all this research. What's been, why do we keep needing to collect? Why is there this need to continue to collect data? So I think sort of really helping people to get access to that and to work together to think about how that could be translated into meaningful approaches to help communities, but also learning from communities about what they're doing to thrive in their communities with regards to well-being and mental health, and giving that same level of respect that we do to the evidence that we generate. So that's one way in which we can, really think about how to go about that, but also representation within research in terms of, service user and public involvement in setting priorities and what questions get asked, really integrating it all the way through the research process. Great, thanks, Sally. So I'm going to move on because there's one final question, and it's addressing a group that we haven't spoken much about, and it's really about thinking about older people and the financial impacts of the pandemic. Now, Phil, who's asked the question, is alluded that financial impacts may be less relevant for this group, but I'm not so sure. So I'm going to slightly rephrase it and just ask the panel, is there much data or analysis about some of the non-financial impacts on the mental health of older people? So thinking about, for example, long-term physical health conditions not being treated, long-term isolation, or bereavement and grief. Tim, can we come to you first?
Yes, of course. So I think there is obviously a wealth of data out there that tries to address these, but maybe not all in one place. Kind of when we look at thinking about the kind of the impacts on sort of older people, that maybe more generally, I'd imagine that there is a challenge, particularly during the pandemic, that this group are probably more likely to have either been clinically extremely vulnerable or being asked to shield. And I'd imagine that would have had would have been a very challenging time for those who have been asked to do that, which could have had impacts on lots of different ways. In terms of the financial impacts, I'm not too sure on data out there, but I might hand over to Neil or Sally, who might have their kind of a better ability to answer that. Neil.
There's a wonderful data set to answer this. It's called ELSA, the English Longitudinal Study for Aging, and it's NatCen, and it's running a COVID panel as well. And I think there are around about 6,000 older people in this. And I do recall that, I mean, overall, I think ONS have had quite a few findings showing that loneliness, well, ONS and others have shown that loneliness has been much greater in younger people because their social lives have been affected. But then when you drill down within older people who are shielding, loneliness is actually a real issue for them. It's just that not all of them happen to be shielding. And that could be particularly pervasive when they're older. The impacts of self-isolation could be slightly more harmful. And also, I think at older ages, self-isolation might lead to lower levels of physical activity in particular, which I think has been overlooked. I never thought I'd say this, but physical activity has been somewhat overlooked. And people talking about mental health. I remember Mark Drayford saying they were keeping gyms open for the benefits to mental health rather than physical health. And that, I think, self-isolating is going to have particularly a harmful impact on older people's physical health.
Great, thank you. And Sally, we just have a few minutes left. Do you have any brief comments?
Only just building on Neil, that I think the other thing that we haven't really talked about is that link between physical and mental health, and in particular that the restrictions on hospital appointments and service contacts is going to have a disproportionate effect on older people. As someone with a mother-in-law whose hip operation was timetabled for March 2020 and still hasn't, got an appointment for a hip operation, I can imagine that is something which is going to be particularly affecting older people now.
Great, thank you all. We just have a few minutes left, so I'm just going to go ahead and close. I wanted to thank the audience for coming today and contributing such thought-provoking questions. I want to thank our speakers for excellent presentations, very clear and informative. And I'd also like to thank the NatCen team for just terrific organization of this webinar, and to the ESRC for their funding and support. And with that, I'll close.